Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion esophageal varices. It is under the upper gastrointestinal bleed. So first one, before getting into the esophageal varices, first we'll see the how we are defining upper GA and then lower GA bleeding. So based on what we are dividing into the upper and then lower GA bleeding. Before that, bleeding from the gastrointestinal tract or hemorrhage from the gastrointestinal tract, it is not a separate disease condition. It is one of the sign or it is one of the symptom. So it is one of the clinical feature or it is a sign or symptom. It's not a separate disease condition, right? So how we are defining the whether that is upper or whether that is a lower GI tract bleeding? Based on the ligament of trites or suspensory muscle of trites. Based on that we are dividing into whether if it is above the ligament of trites means that is upper GI bleed, below the ligament of trites means lower GI bleed. So though we have a question like what is mean by ligament trites? So where it is? There is a next question, right? So in this image you can see that green color portion. This is called ligament of trites. So the other name for the ligament of trites is the ligament of trites also called as a suspensory muscle or suspensory ligament. Okay, suspensory muscle or suspensory ligament. So what is mean by suspensory? Suspensory means so it will hold some part in a specific area, that is called the suspensory. It will hold, it will take hold in some organs or some portion of the body part in a specific area, that is called the suspensory. So we told it is a suspensory muscle. So here exactly it is placed between the diaphragm and then duodenal part. Okay, so this is the area called the ligament of trites. So the major function of the ligament of trites is a first one, as like we told, it will hold duodenum in a specific part. First function. Second function, we told it is a muscle, right? Because of that muscle function, what it will do, the muscle will contract. While contraction, it will facilitate the food content, it will facilitate the movement of the duodenum. So both are the both anatomical and then physiological function is there for the ligament of trites. So this is something regarding the ligament of trites. So based on the ligament of trites, if it is above the ligament of trites bleeding means that is the upper GI bleed, below the ligament of trites means based on the location we are calling as a lower GI bleeding. So based on the incident wise, upper GI bleeding is a more common from the lower GI bleed based on the incidence. So coming into our topic is a esophageal varices. First thing, what is mean by varices? Varices means abnormal enlargement of the vessels. That might be, that can be an artery or that can be a vein or that can be a lymphatic system, lymphatic vessel. So the varices means abnormal enlargement of the vessel. Okay, so that can be, as like I told, it can be artery or it can be a vein or it can be a lymphatic vessels. So here mainly in the esophageal part, mainly it will affect our venous system. So here the term we are organizing means abnormal enlargement of the esophageal vein is called the esophageal varices. Okay, that image we can see. So it is a abnormal enlargement of the veins. So how we can easily remember means, if you remember our varicose vein, there we can see the visibly we can see the enlargement of vein, right? The same thing we can, if you are doing endoscopy means the same enlargement of vein we can see in the esophageal varices. So the majorly it mostly results from the portal hypertension. How the portal hypertension affecting or leads to the esophageal varices means, first we'll it is like it comes under the pathophysiology. So we told the reason for that esophageal varices is a portal hypertension, right? So portal hypertension. So causes for the portal hypertension is a various causes are there. Some of the causes like massive splenomegaly. If any splenomegaly, the most common one is liver cirrhosis is one of the most common factor, and then we can tell us some uh, basically the portal hypertension they will divide into intrahepatic, prehepatic, posthepatic. Okay, so massive splenomegaly and then liver cirrhosis is a common cause. If any thrombus or emboli in the portal venous system, emboli or any thrombus in the portal system also, that will cause the portal hypertension. So hypertension means, so these are the factors, these are the causes. What will happen means, because of these causes, it will increase the pressure in the portal venous system. Okay, it will increase the pressure in the portal venous system, that is called the portal hypertension, increased pressure. Because of the increased pressure, what will happen, the resistance inside the vessel of the resistance will increase. So interluminal resistance will increase. Resistance to what? Resistance to the blood flow. So the blood flow, for the blood flow, the resistance will increase. So whenever the resistance is increased, the flow will reduce. So the flow is reducing means it will back up in the systemic circuit, or it will back up in the distal portion of the vessel, that is causing the esophageal varices. So straightforward, simple. So some of the causes like liver cirrhosis or massive splenomegaly or any embolus or thrombus, that is increasing the pressure inside the portal venous system, that is called the portal hypertension, because of that increased pressure. So increased pressure means it will meantime it will increase the resistance to the blood flow. So if resistance is increasing means what will happen, automatically blood unable to move inside the circulation, so it will back up in the distal portion of the vessel, that is causing the abnormal enlargement of your vein, that the condition is called the esophageal varices. Okay, usually in our venous system there will be a less resistance, but here the resistance will increase, that is what our esophageal varices. In some rather time, if disease progress, if prolonged time the same condition is maintaining means, it will leads to the rupture also. So assessment point wise, in the initial state of disease, so based on the lot of causes we told, in that mainly the person will appear like a liver disease oriented thing. So liver disease means we can see the elevated bilirubin level, that is our jaundice or weight loss. Fatigue also will be there. If any derangement in the coagulation profile also will occur, and then edematous abdomen is one of the cause, pruritus also one of the cause, abdominal pain, nausea, vomiting, these are the some clinical features that initial stage the person will appear. So the disease will the progression of the disease will be take a little more time, so it may take a months to years also it will take, and then the rupture of the varices is also far more sudden. So again, we told it will take a lot of time to coming into the case of rupture of the varices. Mainly, while the time of rupture, the person will complain the abrupt onset of discomfort in the throat. So here, if any if any rupture happen means, suddenly the person will feel the discomfort in the throat region. Okay, that's one of the important thing. Also the person have a hematemesis, and then if based on the bleeding, the person will have a hypotension and then signs of shock. These are the some of the associated clinical features. Sorry. So management wise, so first before handling the whatever case, that might be esophageal varices or that might be a different condition also, first we have to decide whether this case is a stable or unstable. The first category we have to think about the whether the case is stable, unstable. That is why in our assessment and management part, in our format itself, first we have a scene size followed by form a general impression, initial 10-second assessment. So within 10 seconds we have to think about whether this case is stable or unstable. For example, we will take the esophageal varices case itself. So here what is happening, first thing, the main major problem here is a hemorrhage. Okay, that is one of the life threat. So we told the person sometime based on the bleeding, the person may sometime may go into the hypotension shock level also. So first one, hemorrhage, any active hemorrhage is there or not. If active hemorrhage is there means, that is comes under the category of instability. If the active hemorrhage is not there means, then we can consider it a stable case. For temporary, it is not a whole state. For temporary status, the person might be, we can appear like a stable state. Second thing, we have to think about the active hemorrhage is there means, mental status is one of the factor we have to think about, whether the person is conscious, oriented, awake and alert or not. If it is there means, okay, he is somewhat stable. For as of now he is stable. So if the person is drowsy or he is disoriented means he is unstable category. We don't know whenever the person may go into the unconsciousness or stupor level or whichever state he can go because of the drowsy. He can develop in a further more worsening of condition. Because of that, the person may get into the aspiration also. Okay, so if the person is drowsy, if he is not oriented with you means you have to consider it's a unstable thing. Third one, we have to think about the vital signs. So if any orthostatic changes are there or not. Orthostatic changes means any sudden changes in the vital signs. Where mainly we told about the hypotension. Heart rate also we have to think. In hypotension, common reaction is a heart rate. Tachycardia will occur, right? So vital signs, any orthostatic changes. If any orthostatic changes is there means that is comes under the category of instability. If you are not any noticing means that will comes under the category of stability. So these are the some initial, initially we have to make some impression over the person. How it will help us means, so based on the instability, if you define the person as instability means, so quickly you can act based on the scenario, and then you can go for if the person is drowsy, so you can anticipate aspiration, so thereby you can prepare for the intubation, endotracheal intubation or further more things. So if you're noticing active bleeding means, so while securing cannula itself, you can take a sample and then you can intimate the hospital, you can intimate the receiving facility. So likewise the person have a active bleeding, so please arrange for the massive transfusion protocol. So likewise, so you can make some set of initial management strategy, like that is why we have to make a whether the person is stable or unstable. Second most important thing, so based on the instability, so if you thought the person is unstable means, so immediately transport decision also we can make. So in transport, if you divine the person is unstable means, so what we can do, initially we can transport to the nearby facility, that is have a, so for life support we can transport to the nearest hospital. If the person is somewhat appearing like a stable case means, straight away we can take into the gastro facility, definitive care, right? So these are the things will help in the case of general impression. So here also we have to maintain the as like the same thing only. So we have to manage the airway, aggressive suctioning. If the person is continuously bleeding is there means, aggressive suctioning, left lateral position, everything we have to follow over. And then we have to some rather case, if the person is drowsiness means, so we have to anticipate aspiration, thereby we have to manage the airway, secure the airway with the definitive airway. Mainly in hospital what we are doing means the same thing, bleeding control, and then we are doing the aggressive fluid resuscitation. For bleeding control we have some cauterization also we have, and then a balloon tamponade, balloon rubber band, that constrictor also we have those. So those are the some management strategies for the bleeding control. Once the bleeding control stopped means, and then surgical management also, it is the another definitive care for you that is carried over in the inside hospital. Mainly we are focusing on pre-hospital fluid management, and then that active bleeding management. For that bleeding management, we have some one device like called SPT. So the balloon tamponade, that's a device. It's more useful in the pre-hospital region. So some of the article also they are recommending 50 to 90 percentage bleeding control is there, so that effectiveness is there. So SPT is one of the device. I think upcoming presentation we are going to discuss, so we'll see in depth. So do your best. Shalom.